Every successful implant procedure depends on a single absolute requirement: achieving attention free passive fit. The final prosthesis must align perfectly with the implants without exerting any mechanical stress on the surrounding bone. Over the last decade, intraoral scanners or IOS have aggressively replaced analog impression materials. For single crowns and short span bridges, optical scanning captures the three-dimensional spatial data with immense precision. But look at this comparison. On the left, a flawless digital mesh of the single implant unit. On the right, a full arch edentulous scan that distorts and misaligns the true position of the implants. When clinicians push standard intraoral scanners to capture an entire jaw, the technology routinely fails to provide that required passive fit. This failure rate is not the result of poor clinical technique. It is a mathematical breakdown in the mechanics of optics. When forced to scale across wide physical distances, to stop paying for costly full arch remakes, we have to deconstruct the hidden optical vulnerabilities of the iOS workflow and examine the specific computer vision technology engineered to solve them. Traditional elastomeric impressions using materials like PVS or polyether attempted to create a physical negative replica of the mouth. But the physical materials introduce physical errors. This is the distortion equation. Physical impressions suffer cumulative inaccuracies. Trays bend under pressure, materials shrink, and dental stone expands when poured. The digital workflow bypasses these variables. An intraoral scanner emits light directly onto the arch, translating the reflection into a pristine STL surface mesh. Instead of traditional impression copings, the clinician places a scan body. This is a specific asymmetrical geometric marker, usually made of teak or titanium, that acts as a digital proxy for the implant itself. Once the scanner captures the unique shape of that scan body, the software matches the scanned mesh against a preloaded digital library, locking in the precise spatial orientation and the depth of the implant. This optical method yields massive efficiency gains. As this chart shows, conventional impressions take an average of 27.4 minutes, while as digital scanning cuts that down to just 13.2 minutes. Because the STL file renders instantly on a monitor, clinicians can check their work in real time, identifying missing data and correcting the scan before the patient ever leaves the chair. By stripping physical distortion out of the equation, intraoral scanners concord single unit restorations. But that high success rate masks deep limitations, creating a false sense of security for more complex procedure. The transition from physical materials to optics did not eliminate vulnerability. It simply shifted it to the environment. Observe this magnified droplet. Intraoral scanners require an exceptionally dry field. Optical sensors are often far more sensitive to moisture than standard impression materials. When light hits saliva or blood, it physically bends. This refraction alters the angle at which the light returns to the scanner lens. That scattered light corrupts the optical signal. The software interprets the refracted light as a physical geometry, injecting chaotic spiky artifacts directly into the STL mesh. Beyond environmental physics, the digital workflow is bound by algorithmic limitations, most notably path of acquisition errors. An iOS processes 3D space by capturing a rapid fire stream of overlapping data frames, not a single photograph. If the clinician uses a poor scanning path or moves too quickly, the algorithm loses spatial context. The software artificially generates severe errors like rendering phantom teeth. Over a short span of one or two teeth, these refraction and acquisition errors are easily corrected, but when we push the scanner across the full expanse of the jaw, these structural weaknesses fracture the data. The ultimate stress test for optical scanning is the completely edentulous full arch case. To map the entire jaw, the intraoral scanner relies on an algorithmic mechanic called stitching. As the field of view moves across an edentulous arch, the software stitches the frames together to build a continuous map. This algorithm requires distant anatomical landmarks, but healed gums are featureless. Without sharp landmarks, the stitching algorithm slips, slightly misaligning each new frame. On an individual frame, the error is microscopic. But as the scanner traverses the entire arch, those tiny misalignments compound. By the time it reaches the opposite side, the accumulated deviations completely warp the data, throwing calculated implant angulations wildly out of position. The danger is that the final STL file on the clinical monitor will often look perfectly smooth and connected, actively masking the fact that the underlying spatial coordinates are entirely false. This geometric breakdown in stitching guarantees a loss of passive fit. To successfully restore a full arch, clinicians require a technology that abandons stitching entirely. To bypass the failure of surface scanning, modern digital dentistry utilizes a specialized technology for complex all on X cases, photogrammetry. Photogrammetry separates itself from intraoral band physically. It operates on an extraoral camera positioned outside the patient's mouth. Algorithmically, it completely abandons the generation of a continuous surface mesh. Photogrammetry utilizes an array of extraoral lenses taking simultaneous multi-angle snapshots of geometric markers called dominoes attached to the implants rather than overlapping video frames. The system relies on geometric triangulation. By analyzing multiple angles simultaneously, the software calculates precise 3D coordinates for the implants, but it does not stitch images or render soft tissue. It avoids the compounding errors of intraoral band, achieving spatial accuracy down roughly to 5 micrometers. At 5 microns of precision, the clinical workflow accelerates dramatically. By replacing guesswork with absolute geometric triangulation, photogrammetry mathematically guarantees a passive fit, allowing clinicians to skip the fabrication of labor intensive resin verification jigs. This matrix reveals a clear progression. Analog methods suffered physical distortion. Intraoral scanners bypassed this, succeeding for single units. But their stitching algorithms fail on featureless arches. Photogrammetry provides the definitive answer. Triangulation secures the precise 3D implant position, guaranteeing a tension free fit. Adopting photogrammetry for full arches is not an elective luxury or a matter of clinical preference. It is mechanical necessity born directly from the limits of light and software. Understanding the exact mathematical boundaries of our clinical tools is the only reliable way to consistently achieve the uncompromising, tension free standard required in modern digital implantology.